Great. Yes, thank you again for that introduction. Great to be here. As Kirsten mentioned, I am part of City of Hope now. I just joined City of Hope. It's been my fourth week actually. So very new there at City of Hope, and I apologize to Doug over there that I didn't get the slides that have the City of Hope banner over it. So please bear with me. So the title of my talk this morning is Go See a Sarcoma Specialist and How to Prepare for This. And I did this in mind for you guys as patients and caregivers and family members for someone who is diagnosed with sarcoma, and kind of thinking about if you have a new diagnosis of sarcoma. But this could also apply if it's not a new diagnosis. So I hope you find this helpful. For my disclosures, I really don't have any, but I do get the small stipend from Up to Date for the chapter on retroperitoneal sarcoma. And one of my disclosures is that I do have kind of a strange sense of humor that you guys may not agree with. But while I was preparing for this talk, this was on my desk calendar. I'm a big fan of Far Side, if anybody remembers that. And then this came because if you think of cancer as a crab, well, that's how I picture sarcoma. Sarcoma is very near and dear to my heart, but it's often one of the crabs, so to speak, that's not in the main box. It's not in the mainstream spotlight. It's often kind of ignored, and it's really not in the spotlight, is what I'm trying to say. But my other disclosures for this talk is that I'm, first of all, a surgeon, as mentioned. So I'm not a medical oncologist. I can't really talk to you about clinical trials. I do try to engage with the medical oncologists in my institution, but anyways, I'm a surgeon by training. And then I also focus mostly on adult sarcomas, not pediatric sarcomas, although those are very important as well. I also focus more on soft tissue sarcoma and not bone sarcomas. I hate to make all these disclaimers, but I wanted to say this up front so that you know that the subsequent slides are a little biased towards my own practice. And then also I practice in Los Angeles, obviously, so some of the discussion will be based on the Los Angeles healthcare environment. So the main issue, the background behind this talk is this, and that's that less than 50%, less than half of sarcoma patients in the United States are currently seeing a specialist. If you look at extremity and trunk sarcoma, again, this is soft tissue sarcoma, but only 40% of patients actually see a sarcoma specialist. This statistic is even worse, even more shocking for retroperitoneal sarcoma. Retroperitoneal sarcoma are the tumors in the back of the abdomen. So only 10% of patients with sarcoma in this location see a specialist. This is based on US National Cancer Database. So that's why I'm very passionate about this topic and very passionate about this title, Go See a Sarcoma Specialist. I've been with the Sarcoma Alliance for several years now, and when I first participated as part of the Medical Advisory Board, this was one of the editorials that I wrote with that exact same title, Go See a Sarcoma Specialist. And now, 4 years later, I'm saying the same thing and trying to say this more and trying to get more people to recognize the importance of this. I've even done this in Chinese, although to be honest, I don't really speak Chinese. So hopefully that is what that says. So the outline of my talk this morning, so what we're going to do, we're going to go back to number 2 towards the end of the talk, why see a sarcoma specialist. But I thought I'd start off by presenting to you guys my perspective on how and what to prepare to see a sarcoma specialist. This is with the assumption that everybody in this room and everybody listening agrees that it is important to see a sarcoma specialist. And the reason to do this really is so that you, as the patient or the caregiver or family member, has a meaningful and expeditious opinion with a sarcoma specialist. And I put that there, that emoji. I never really figured out what that emoji is. I think it's a thank you, but it's also a way for me to say, as a practicing clinician, if you do these things, how and what to prepare to see a sarcoma specialist, it helps the clinician out tremendously. So how to prepare to see a sarcoma specialist? Well, first of all, I think it's very important to be familiar with your history. In medical terms, that's called HPI, or history of present illness. But some of the features of that are for new diagnosis, briefly, what led to this, what led to your diagnosis, the symptoms that were associated with it. And if it's no symptoms, which can be the case, or vague symptoms, unclear, just a fullness in the abdomen, those are important to know for the specialist you're about to see. And then what happened next? What was what we call that the workup? Did you get a CT scan, an MRI? Was a biopsy done? And if treatment was started, what kind of treatment was actually started? For patients that have recurrent disease, well, you guys are familiar with your diagnosis, but for the sarcoma specialist that you're about to see, just brief details about when you were first diagnosed, then the treatment history with approximate dates. I'm very much a stickler, let's say, for dates. It doesn't have to be that exact day you were diagnosed, but just 2019 or summer of 2019, something like that. And then currently, what's going on with the disease? Is it progressing? Is it stable? Is it going out of control? Or what's the reason for seeing a sarcoma specialist? And then I think for yourself as a patient, if I may say, I think it's important for you to really clarify and define your goals for the visit that you're about to have, and also your goals for the treatment, whatever is going to be proposed, but your goals for treatment. And with the visit, is it the purpose of the visit to learn all the different options that are out there? Or is this truly a second opinion where you've already seen one or maybe even a third opinion, you've already seen a second sarcoma specialist, and you kind of want to confirm the treatment plan that was presented to you? And then I think this next bullet point is very important, to be able to clarify for yourself going into this visit what you really want to achieve. Realistically, do you want to achieve cure? Of course, all of us want to achieve cure. All of us really do, but it may not. It's different for every patient's situation. Is it a stable disease? Is it quality of life? The quality of life, I think, is very important. And then how to prepare for your visit, self-education. So learn all you can about sarcoma. And I really say that. I think you guys all know that. I for one, love it when a patient comes to me and already knows so much about sarcoma. When a patient knows more than their primary care doctor about what sarcoma is. Because keep in mind that it's such a rare disease, it's a challenging disease. Most physicians that are well-trained may not see sarcoma for several years or only once or twice in their lifetime. But for yourself to learn all about sarcoma, learn as much as you can tolerate, let's say, that's very important. And that's where Sarcoma Alliance can can help with that and play an important role, as we have a lot of resources online and to help you learn about sarcoma and your specific type of sarcoma. So on that note, just one brief slide about Sarcoma 101. Gina has talked about this, and others have talked about it, but just, if anything, this one slide. Sarcoma, rare disease, affects all age groups. Again, children, adolescents, adults, elderly. And then I think it's also interesting, or it's important to recognize that there are really no risk factors for sarcoma. And what I mean by that is smoking, obesity, alcohol intake, they don't really predispose you or put you at a higher risk for developing sarcoma, unlike other cancers. At the same time, unlike other cancers, there's no prevention or screening. There's no mammogram, like patients with breast cancer can have that as part of their screening, or colonoscopy for colon cancer. I think those last 2 points, all of these points are very unique about what's unique about sarcoma. Sarcoma also presents very subtly. Many of you may already know yourself. It may be just a vague symptom, something not, it doesn't have to be pain. A lot of patients do not have pain as their initial presenting symptom. And then when you get down to the diagnosis, it's very challenging. When I say sarcoma specialist, that also includes a sarcoma pathologist. You guys may not actually see that person, but it's important to for your case to be evaluated by the clinician as well as a sarcoma pathologist. And what makes it challenging is that there are over 100 different, I think this is one of the trivia questions last night, but there are over 100 different histologic types. And I put histologic because you'll see that term thrown around. Histology means what the cells look like, what the tissues look like under the microscope. But it's basically referring to the different types of sarcoma. Liposarcoma arises from fat, leiomyosarcoma from smooth muscle, et cetera, et cetera. So that wine, why I put that wine picture is I often use that analogy of wine with my own patients. And the analogy is that sarcoma is like wine in that there are different, I'm not a wine expert, but different varieties or nuances to sarcoma, just like there are wine. And then this is also very important that sarcoma is not organ specific. So if you see so for breast cancer patients, when they see a breast surgeon, it's only, for the surgical part, it's only in the breast, whereas sarcoma can occur anywhere in the body. The most common location is the extremity, arms and the leg, but also the retroperitoneum or abdomen, the back of the abdomen. And all of this is important to recognize because when you're going to see that sarcoma specialist and they're about to form a treatment plan for you, the treatment is really tailored to the type of sarcoma you have, again, the histologic type, as well as the location. So what that means for location, if you have a liposarcoma of the extremity, the treatment may be different or is different from liposarcoma of the retroperitoneum. So same histologic type, but different location, treatment may be very different. And then also just know that unfortunately there is this concept of a whoops operation. I put that in gray, but that is it's what it sounds like. It's when a patient is treated and managed by someone who's not familiar with this disease and does the wrong operation or gives the wrong treatment. And then so what to prepare, I'll try to go through this quickly. And these are suggestions. And I put this here, this is kind of for those of you who want to be more organized and also to know your own case as well. Because a lot of times this will be requested by the sarcoma specialist, that his or her office or the hospital may request these. But I think it doesn't hurt to have this in front of you in an organized way and also to understand your own case. So I think what's important for that sarcoma specialist to evaluate are these things: the pathology report, the radiology report, operative report if you've had surgery, and then clinic notes from medical oncology and radiation oncology. And then what's also helpful are these things: pathology slides. We'll show details of each of these briefly. But pathology slides, radiology images, and what I'm referring to is the actual CD that has the CT scan or the MRI that the specialist can look at. And then if you have significant medical conditions, so if you have heart disease, lung disease, something that you see another doctor for on a regular basis, that's important to know and to have a clinic note from that. This can be very overwhelming. I think this slide is already a little overwhelming, but if anything, the most recent notes, I think that is what's the most helpful for the specialist you're about to see. So pathology report and slides. And for each of these categories, I start off by saying why, just so you understand what we're looking for as the sarcoma specialist, why we need these things. And this is, of course, to confirm the diagnosis. Very important to make sure you do have a sarcoma, that it's not a benign condition. As an example, with liposarcoma, there's lipoma, which is benign, and there's also a variety of different types of lipomas that are all benign, and sometimes they get confused with liposarcoma. They're rare, but in that off chance that you actually don't have a liposarcoma and your pathology was incorrect and you have a lipoma, that's why it's important to get the pathology report, because your specialist will be looking at that pathology report. And notice that I'm a surgeon, but I do study that pathology report extensively to make sure that for liposarcoma, it says MDM2 amplification or DDIT3 translocation. You know, those are things that are very familiar part of my practice. But to confirm the diagnosis, and then within that diagnosis, the type and the subtype of sarcoma. And then for medical oncologists, again, I'm not a medical oncologist, but this helps. The pathology report can help to customize and personalize your treatment and to help select the best drug therapy. And then when I refer to slides, so I stole this image off of Google, just full disclosures, but that's what I'm actually referring to. So slides are just like, if you think back to high school, the actual glass, that's actually the purple, those little blobs, not the plastic things, but those blobs on the slide, that's actually a piece of tissue from your biopsy or from surgery that a pathologist has mounted onto a glass slide. So when I say get the slides, and I do have many patients who actually they are proactive and they go to their hospital, get these slides, get the blocks to bring to the hospital that you're about to see the sarcoma specialist at. And this is important for re-review. A lot of times that diagnosis is incorrect or needs to be verified. And then also the blocks, those are the white things. Again, that little blob there is a piece of tissue. But those blocks can sometimes be sent off for additional testing to look at the genetic profile of the tumor that can help select therapy or help to customize your therapy for the medical oncologist. Radiology report and imaging, again, the most recent. And the reason why is to help understand the extent of the tumor for surgery. That's for, if I'm about to do an operation, I definitely need the radiology to understand the relationship of the tumor to major blood vessels or important organs and structures. And then to assess for spread. So the medical term for spread is metastasis. But what we're looking for is, has it gone to the lungs? Is there a suspicious lesion in the liver? To look for evidence of spread. And then for medical oncology, the radiology is obviously important to, if you're on therapy and getting treated, it's important to follow, say, CT scans to see if the tumor is responding. And this is usually a CT or an MRI. This is in terms of what to look out for, because you could have any variety of radiology studies done. Usually it's a CT or an MRI. Sometimes it's a PET scan. Again, depends on the institution that you're about to go see. Occasionally chest X-rays, very rarely ultrasound. And I put avoid anything else just because those are the main ones that we usually look at, especially CT and MRI. And then when I talk about CD, just if you're not clear about this yet, it's actually a CD. It looks like that. And this is, we much rather prefer an official hospital copy rather than a burned copy, because I can tell you there's so many times when we get a burned copy that just doesn't work. And you have the patient in front of you, and it's very frustrating, of course, to the patient, because they may have traveled a distance to come in and see this sarcoma specialist. And then I don't know what to say, and I'm not technically savvy at all. And if we don't have the images, it's not a very productive a visit. And this is also why I say, if possible, bring it in advance of the visit. If that's mailing it to the appropriate place a week, 2 weeks in advance, or bringing it in a few days before your visit, the day before, that's helpful. So operative or surgery report. Now I realize for new diagnosis, many patients may not have this, and then on the flip side, if you've had multiple surgeries, the most recent one is the most helpful. The reason to do this is to understand the details of the prior surgery, obviously, and for sarcoma. So you're seeing a sarcoma specialist, so it's intuitive that what I really care about, or that's not the right way to say it, what's most relevant is is the sarcoma operation. So I don't need to know about the knee operation that you had, or even the, if it's relevant to sarcoma, that's what I'm looking for. And then also, of course, the surgeon may speak to the prior surgeon. So I often do call whoever your prior surgeon was just to get an idea of what they did at the previous operation. And if you've had multiple surgeries, as I said, approximate dates and what was done generally, like was a kidney removed, was the colon removed? We can kind of tell looking at the radiology images, again, the images, but there are also instances where the radiologists miss that. You know, they'll say that there's a spleen in the left upper quadrant of the abdomen when the patient's already had a splenectomy, and that's actually a tumor that's there. So anyways, so the clinic note for medical oncology and radiation oncology, and again, this is biased towards my view as a surgeon. The most recent one, and part of that is just because I'm kind of too lazy to read through 5 or 6, I'm sorry, Gina, try to read through 5 or 6 different medical oncology notes that can be very detailed, let's say. So just the most recent one for me, and this is to understand the details of prior therapy and the plan for therapy. I usually just skip to the assessment and plan. And then the oncologist may speak to a prior oncologist. And for me, it's a nice summary of the therapy. So despite making jokes about how these can be very long notes, they do provide a nice summary of patient had surgery, patient had radiation, had this drug therapy, then this drug therapy, then this, and then surgery. So for complicated cases in recurrent disease, metastatic disease, multiple treatments, I often look to the last note for a nice summary of what the patients had up to this point. Okay, significant medical conditions, again, if relevant, and this is to consider for treatment planning. And what I mean by that is, most importantly, cardiac. If you have significant cardiac issues, such as listed there, if you've had a heart attack before, pacemaker, heart failure, the specialist will gather this information just by talking to you and looking through the records. But this is important because this would affect, say, the regimen, the drug treatment that the specialist, if it's a medical oncologist, the regimen that the medical oncologist is about to recommend to you. It also affects me as a surgeon, because if you have significant medical conditions, those need to be what we call cleared, or at least we need to try to optimize them as best as possible before undergoing a major operation. And that also translates into there may be delay in terms of we may not be able to do the surgery in 2 weeks until you get the cardiac cath to study your heart, or until you get a stent to optimize your cardiac function. I've had patients do this, which I love, which is for the doctors that they see for each of their medical conditions. They're super organized, and they have these card holders, business card holders. So anyways, to summarize what to prepare, this is, and I think you guys should have access to these slides. Again, some patients are very organized and have a 3-ring binder. I'm not saying you need to have this to see me. It's not a prerequisite to come to City of Hope. At least I don't think so, Doug. but this is very helpful, and I think it's helpful for you as a patient to kind of have all of your treatment organized, your thoughts. You can have a tab with articles that you've read, or a question about something that you saw on the internet. That could be like the last tab or something. So I think it's good to be organized. And of course, questions. Bring your list of questions, have them written down. I think that's maybe one of the most important things of the visit, of course. And then for the treatment, always ask about benefits, the benefits of treatment, the risks of treatment, the alternatives. So if we're talking about surgery, if we don't do surgery, what's going to happen? And then the anticipated outcomes. If you do surgery, do we expect that the tumor will come back in 6 months, or do we expect that it will be essentially cured and you'll never see the tumor again? What's the anticipated outcome? And then always maintain good communication. I think and that communication could be even after the visit as well, keeping in touch with that doctor. If you have further questions, if you've seen somebody else and they bring up another question, if you change your mind and you decide you're not going to go, you're going to go with your local surgeon, let's say, that's fine. There's nothing but just keep in touch with the doctor, the specialist that you just saw. Okay. So I hope that was helpful. I just wanted to go back to the original. Remember, the title of my talk is Go See a Sarcoma Specialist. The question then, of course, is why see a sarcoma specialist? And I think for most of you in the room and those listening, it's probably pretty obvious and pretty intuitive. Along with that question, I do also want to say what defines a sarcoma specialist or a center. And we're kind of taking a step back because at this point, you've already seen your sarcoma specialist. But just kind of think, and I welcome any feedback about what you guys think is what defines a sarcoma specialist. So the answer to the question, why see a sarcoma specialist, is that outcomes are better they are better. I should emphasize that. That was highlighted in one of my earlier versions, but outcomes are better for patients that are seen in a sarcoma center. This is very intuitive. I think it makes sense, but if you need the literature, those are many of the recent studies that have shown this. This is one study that I highlight in France. They have a very organized network of sarcoma centers. It's called NetSarc. And when you look at the patients in green versus in blue, the ones that are seen at a sarcoma center that are referred to one of their sarcoma centers and get their treatment there, they have better overall survival. I think this is also very important, especially for the rare sarcomas. I had a conversation last night with somebody from a company that represents PCOMA. That's a rare of the rare. And we may not have this data to say that it's better for PCOMA patients to be seen at a sarcoma center. But I would argue it's probably, we don't need the data. For something that's that rare, you want to go see a specialist. But this applies for all sarcomas, bone and soft tissue as well. And then what defines a sarcoma center? So the studies that I just cited, this is defined in those studies by a threshold volume. So it's the number of patients that are seen. I'll give you details about what that number is, but it's basically the number of patients, a certain cutoff that they say, this is what, if you're above that cutoff, that center is a sarcoma center, a specialist center. And it's usually a top percentile, top 1% of number of patients seen. We do have, here at Sarcoma Alliance, we do have a sarcoma center list, and it's the URL is listed there. Although, I hope I don't get in trouble for saying this, but it is a work in progress. It's something that we're, as a group, we're working to improve. So definitely visit that, but just know that in the next year or so, we're going to continue to work on refining that list. So what defines a sarcoma center? And I would say that, first of all, in the United States, besides volume, we don't really have good established criteria for what is a sarcoma center. And I say this is in comparison to, say, pancreatic cancer or breast cancer, where they have centers of excellence and define criteria, committees that define this and that audit centers. Well, we don't have this in sarcoma. Just realize that. So I would say that it's more than just volume, more than that threshold volume that I showed on the previous slide. In Europe, and this is not to try to say Europe is any better than the US or US is better than in the US. In Europe, they do have these guidelines. I do a lot of collaboration with sarcoma colleagues in Europe, and I'll tell you that even though this is published in 2017, I don't know how strictly they adhere to this, but at least there's more thought that it's more than just volume. And then these next slides are my 2 cents, my opinion. But I would say that these are shared by other sarcoma specialists, my colleagues. But it's more than just volume. Volume is, of course, important, but the experience of the physicians, the team that is at that sarcoma center, as well as contribution to the field. So with volume, so these are the numbers that I promised you, and this is based on multiple sources, including our own Sarcoma Alliance website. So for a single provider, This is referring to new patients. It'd be either somewhere from 20 to 40 new patients per year. This actually, in these studies, it defines that sarcoma center, so the specialist. And then for center, over 100 patients seen per year. Now, keep in mind, that's just a cutoff number. So if you go to specific centers that I won't name, I'm not trying to support one center or another, but some centers see 500 patients a year. They way exceed that threshold. For what I treat retroperitoneal sarcoma, you might be surprised to see that is the cutoff, 10 to 13. So for a center to see 10, 13 patients, let's say 13 new patients per year, that's per year, that qualifies as the top 1% of retroperitoneal sarcoma centers. So if that's what you have, it gives you an idea of how rare it is and what it really means to be a specialized center. And then for the experience and contribution, so the experience, again, this is just my 2 cents, but besides fellowship training in surgical oncology, medical oncology, radiation oncology, some of us in the field actually do have additional extra training or let's say early mentorship in sarcoma. And then also dedication to sarcoma. Again, my 2 cents, but there are people that only do sarcoma. There are good clinicians that will treat sarcoma, and again, good clinicians that will treat sarcoma, breast cancer, colon cancer, other cancers, and sarcoma may make up 40% of their practice. But my 2 cents, I think it's important to strive for, let's say strive for that goal of just treating sarcoma. And then society participation, that means that the sarcoma specialist or sarcoma center is actively engaged with colleagues within the field. So that center is just not acting in isolation and practicing the same medicine, so to speak, for the last 20 years, and gets involved in the field, publishes their findings, works with other centers to really advance the field. So that's research, publications, collaboration. But most importantly, though, at the very center, is the ability to have multidisciplinary discussion. For a center to have a surgeon, medical oncologist, radiation oncologist, even a pathologist. Remember, we talked about the importance of a pathologist, radiologist, all dedicated to sarcoma and having what are called tumor boards. Those are regular meetings. Most sarcoma centers have meetings every week, if not more frequently than that, to get together and discuss the patients that they've all individually seen or that they share in that center. And then do we need a better definition of sarcoma center in the US? Again, my 2 cents, but I think yes. And the reason I feel so passionate about this is one of the reasons is that issue that I said about that not enough patients are seen with sarcoma are seen by specialists. But overall, the goal is to facilitate the best care possible for sarcoma patients, just given that it's a rare disease, that it's a complex disease, and that it's also, keep in mind, it's also a challenging disease. It's a challenging disease even for a sarcoma specialist, let alone somebody that is not familiar with the disease. So to facilitate the best care possible, I definitely feel that we need a better definition of what is a sarcoma center in the United States. This also will help to set standards in our field, higher standards, quality control, and then importantly to optimize research and clinical trial enrollment. So if a patient is eligible for a clinical trial that's looking at specifically PCOMA, let's say, and there's not that many centers around there, I'd rather have that patient not be lost, so to speak, in a non-specialist center, and to at least get an opinion at a specialist center to see if they qualify for that particular trial. Because the enrollment for a lot of these clinical trials that Mark Golnick spoke about yesterday, it can be very challenging to enroll enough patients, especially for some of the rare subtypes. And then my goal would be to get a better definition of sarcoma center to help convince healthcare systems, insurance companies about the importance of authorizing a referral to a sarcoma center. I see some heads nodding, and I think here in the Los Angeles, Southern California environment, that is very important, because I can tell you there are so many times that patients will come to me and say, I would like to see you or come to your center, but the insurance doesn't approve of it. And so then it becomes, are you willing to pay out of pocket cash for it? So if we could use this as if we have a good definition of sarcoma center, this will help to make that argument. And of course, this is a work in progress. Okay. And the last slide, last couple of slides, I just want to leave you with the thought that always maintain your hope, always maintain the strength that I know all of you guys have as you're facing this disease. And that's whether you see a specialist or not. No matter who you see, stay strong and remain hopeful. And yes, so I wanted to thank you for your attention. That's my contact information. I am on social media, so feel free to follow me if you'd like. I just reached 1,000 followers on Instagram, so I'm very excited about that. And I didn't pay anybody. It's all organic. Yes. And that's just my son. I have a 5-year-old son, and he's into Plants vs. Zombies recently. And independent of what, he doesn't know really what I do. He knows that Daddy removes tumors. That's all that he knows. But it's funny that, and I'm not making this up, one of his favorite character is that sunflower. For some reason, he likes the sunflower a lot. The other one on the left side, that's bonk choy. It's a bok choy, and that's cherry bomb. But his favorite is actually the sunflower. It's called sunflower. I think he actually leads all the plants in the fight against zombies in that game. I don't know. But okay, thank you again.
Does anyone have any questions here in the room before we go to virtual? And yes.
I was just wondering, so if we're being seen at a sarcoma center, can we assume that there is a pathologist there that specializes in sarcoma?
Assume that there's, so the question is do you assume that there's a pathologist at that center that specializes in sarcoma?
Yeah, if I'm being seen at a sarcoma center.
Most of the time, yes, but not 100%.
Okay.
Yeah.
There was a question
I
online.
got it, Charles.
Over the last 2 years, because of the pandemic, traveling has been difficult. So
Yes.
do you have any thoughts about telehealth consultations?
Yes, yes. And part of the reason I'm so passionate about this topic is I think as a field, meaning in sarcoma, we should be able to try to leverage that more, to be able to use telehealth to provide a second opinion. The caveat to that, though, is that going from state to state, there are certain states that have restrictions. If I'm in California, I may not be able to see a patient in Florida. And then each institution has its own rules about what to do. It's mostly governed by what the state laws are. One way around that I found is that if the, and I'm not sure about the City of Hope policy, honestly, but at least at my previous institution, if you if say the patient is in Florida, I'm in California, if the patient has a local physician that's on that call, on that consultation, it could be anybody. It could be a primary care doctor, the medical oncologist, but if the patient has that local physician on the call, then it's okay. That's my understanding. But if any of you guys have input on that, but definitely, I think we should try to leverage and use telemedicine more.
Thank you, Dr. Tseng. We have 2 questions online. The first one is, if a patient has been told their uterine leiomyosarcoma tumor is inoperable by a tumor board, what is your feeling about getting a second opinion? The original tumor was removed in 2019, but has recurred.
I definitely think you should get a second opinion. For unresectable, now That's me. I tend to be a little bit more, maybe it's a aggressive in a safe way, but unresectable means that you cannot remove it, that it's, there's no option for surgery. I think that is, if somebody tells you that it's unresectable, you should see somebody else to verify that it is unresectable. If you have 2 out of 2 or 3 out of 3, then it probably is unresectable, unfortunately. But you may find another surgeon, but also it has to be a safe surgeon as well. You don't want somebody that just says, oh, sure, I can take it out, or take out part of it and not tell you, something like that. But it's important when I think when you get that word unresectable, that to really make sure it is unresectable.
Thank you. We had another person who asked, would the pathology report be in the hospital's medical records?
Yes.
Okay, that's it for online questions right now.
Anyone else here in the room? Oh, yes, be right there.
How important is it to get the pathology slides, and is it pretty easy to get from pathology here?
It depends on the second question, how easy it is. It depends on the institution. But how important is it to get the slides? I'd say for sure the report. The slides, sometimes they may not be necessary. So if it's an adequate report, or if it's been, basically if it's an adequate report, you may, the sarcoma specialist may not need the slides. Yes.
Now, how do you know when you need a second opinion? I'm recently diagnosed, and it was through a whoops operation, but I was with a Southern California medical provider that had a sarcoma center, and the general surgeon referred me straight over there, and everything happens fast. And I don't see any problems, but everybody says second opinion, second opinion.
Yeah, it's a good question. It is a case by case basis, and it's also hard for me to say that, oh, that one place that you went to is not a sarcoma center. But I think in general though, it'd probably be helpful just because of the rarity of the disease, the complexity of the disease. And if I may apply your specific situation, the whoops operation that you had, it kind of makes it a little bit more complicated. And so I would say by default, it's important to see it, to go to get a second opinion. Mm-hmm.
The general surgeon meeting with you and referred me to the sarcoma center.
Yeah. Well, if you've already, if you've already seen, and we could talk about this more offline, but if you've already seen a sarcoma specialist at UCLA, then if you feel comfortable with that sarcoma specialist in the plan, it's not absolutely necessary, no. But we could talk more. I don't know your individual situation.
Yeah, I think instead of thinking of it as a second opinion, I think it should be an expert opinion. So a sarcoma expert opinion. So sometimes, so you want to be making sure that you're being seen by a sarcoma expert and get the opinion of the sarcoma expert. So kind of think of it as an expert opinion, because sometimes sarcoma experts have different opinions, and then you wind up going to all these different experts and getting second opinions and third opinions, and then your head spins. But I think it's important that as long as you get it by an expert opinion and it's a reputable sarcoma center, then I think you should be in good shape, and you don't have to be going for multiple second opinions.